Good afternoon, and welcome to Plante Moran's webinar on healthcare reform, your guide to exchanges, public and private. My name is Tony Colarosi, and I'll be administrating today's webinar. A couple of housekeeping items for everybody on the webinar today. The slides are available for download from your webcast console, and a recording of today's webinar will be added to our website in just a few days. We will allow time at the end of the presentation to respond to any questions, but please feel free to submit questions at any time. This is a CPE eligible webinar. Throughout the webcast, participation pop-ups will appear. Participants must respond to at least 75% of these pop-ups in order to receive CPE credit. You need to be logged in as an individual to the webinar to meet your CPE credit, and you must meet the eligibility requirements, which includes having accrued viewing time of at least 50 minutes and 75% response to the participation tracking. Only attendees who are logged into the webinar will be eligible to earn the CPE credit. Again, my name is Tony Colarosi. I'm a partner with Healthcare Consulting. I'd like to introduce a couple other presenters for today. James Minutolo is a senior manager with our firm. He works principally in our National Tax Office. He has extensive experience in tax planning with special focus on mergers, acquisitions, and distressed businesses. Welcome, James.
Thanks, Tony.
Michael Krucker is with us today. He's an associate with our Employee Benefits Consulting Group. He's also an attorney, so he's going to have lots to say to us today. Welcome, Michael. We also have Scott McCullen. Scott is a member of our Plante Moran Group Benefit Advisories, and he has spent a significant amount of time over the last several months helping his clients understand the impact of healthcare reform on their overall benefit strategy. Welcome, Scott.
Thank you.
We have a couple of overview slides here for everyone. First is, for the last 2 years, we've known that public exchanges are going to be present in the new marketplace. Today, as it stands, about half of all of the states have chosen to have the federal government actually manage and administrate the exchanges. About 7 have decided to operate them as state exchanges, and the remainder have opted to work in a collaborative arrangement with the federal government. Why are exchanges being created? Well, it's fairly simple. Starting 3 years ago, we started to approach about 50 million uninsured in the United States. Of that amount, the idea was if we could group individuals into new pockets of insured populations, that we could reduce that down to about 3% of the total population in the United States being uninsured. To do that, the Affordable Care Act created a couple of new opportunities. The first is an expansion of Medicaid. And through the expansion of Medicaid, they're looking at adding about 18 or 19 million people throughout the United States into Medicaid, new Medicaid programs. The other options were exchanges. And there's 2 opportunities for exchanges under the Affordable Care Act. A state exchange, which is principally for those with an income less than 400% of the national poverty limit. But they also open it up for things for employers through private exchanges, and we're going to cover both of these opportunities. So the idea is to take that uninsured population of 50 million and reduce that down to somewhere around 7 or 8 million people that will be uninsured when this is fully implemented. We have our first polling question. We'd like to ask you, what do you believe is the most likely impact of the public exchanges? A, fewer uninsured individuals. B, slower growth in the cost of health coverage. C, fewer options for small employers. Or D, no significant change. And as we're looking through this, we have about half the respondents that have submitted their response. Wait a couple more minutes, and here we go. About half of the individuals believe that the likely impact is going to be fewer uninsured individuals. But close behind is C, fewer options for small employers. I'll ask our presenters today, does that surprise you in any way?
Perhaps a little bit, Tony. I think that the fewer uninsured is clearly the focus of the Affordable Care Act. Although I will tell you that that at least it is the hope of the people who designed the Affordable Care Act that the exchanges will drive down costs somewhat by increasing competition. A lot of this is yet to be seen, and I think it, at a certain level, doesn't necessarily surprise me that there's a lot of pessimism out there that anything will ever slow down the growth of inflation in the healthcare area. It will, and on the fewer options for smaller employees, that's an interesting issue because there's a lot of debate. Is the healthcare reform really going to end up driving all the health plans to fit into one or two or three very similar pockets, much more moving healthcare much more toward a commodity kind of situation than what we have now, which is a very diverse arrangement where plans have the variety of plans that are available is incredible. So ultimately, I think our voters may have hit this one right on the nose. I mean, the likelihood that it's going to slow inflation in the healthcare market, I think a lot of people are doubtful, and I think you may well see most health plans starting to gravitate toward a similar mean where they're all going to be very similar to one another.
Thank you, James. This next slide, just in a very simple manner, describes what's happening with the public and the private exchanges. The public exchanges are really available to individuals and also to employers that have less than 50 employees, while the private exchanges are really set up by providers or groups of providers or employers to specifically address a population. The distribution and how the exchanges work is that individual carriers will submit plans to the exchange, and the exchange really just administrates the selection of plans by individuals. And in this circumstance here, we have 4 carriers that are submitting a plan to the exchange. There are differences between the state exchanges and the private exchanges. So starting off real quick, when you look at state exchanges, we already talked about you could have it managed by the state itself, in which case, they're going to collect the premiums, they're going to operate the website. Everything that has to do with the exchange operation is under the control of the state. They can opt for certain things to be deferred to the federal government, however. In a partnership, the state really just takes on plan management, and everything else in the background is managed by the federal government. Or if you have a federally facilitated, it's basically deferring to the federal government to run the plan, and the state has certain rights to control minor parts of the operation. Private exchanges are entirely different. Private exchanges can really be constructed for very, very narrow networks, where an individual provider health system can get together with an insurer, craft up a plan that's structured for a particular population that they want to be attentive to. It could be a particular employer in their marketplace that they want to attend to. And they can promote that to their employees. Alternatively, you could have a multi-carrier private exchange. In this situation, it becomes almost like a cafeteria plan where the exchange, the website that's set up, has multiple options for employees, and they can select from whatever is best for their situation. And lastly is a co-op, and the co-ops are also being funded and have been funded by the federal government in such a way that you get an aggregation of small businesses together to offer up a consumer-operated and oriented plan. This slide here talks about how exchanges operate. If you think about it as there is a health plan that wants to offer insurance, and they're going to meet all of the requirements that James and Mike are going to cover, but there's a whole bunch of requirements that they have to minimally provide to the beneficiaries. And they submit that, and they do plan development, they do anything that has to do with pricing. They structure all the normal insurance functions. They offer that through an exchange that does enrollment. When does somebody become actively enrolled in the program? That manages the premium billing, which gets very, very complex because the way the exchanges are set up, there's a component that will be paid by the federal government, and there's also a component that potentially could be paid by the individual. So the premium billing and at what point in time does the aggregation of both sides of that premium actually activate the individual to have insurance is part of the complexity of these exchanges. Then the public exchange itself is the brokerage of the product. It's doing the reinsurance and all the background items that have to be in place in order to make sure it's a secure operation. One last slide here before I turn this over. The idea of narrow networks is an idea that's getting a lot of play in the marketplace today. When you look at a narrow network, it's almost as if you're trying to re-implement some of the health management HMO type of operations from years gone by. We want to create a structure that says we have only selected the best, the highest quality, most efficient, value-oriented providers to be part of our network. And if you want to have a stabilized premium, perhaps something that's more cost-effective than the other alternatives that are out there, if you want a quality, high-quality provider network, choose us. And it's going to have much more options for individuals to say, do I want to have the breadth to choose the widest network possible so I can go anywhere within our community, or am I going to dig a little bit deeper and find out what makes these superb options for us as far as this very, very narrow network? There's going to be many, many options that are offered on the exchanges, and they're going to be offered in an illustrative way, and we have an example further on in our presentation to make it very, very easy for consumers to select which is the best option for them and their family. At this point, I'm going to turn it over to Michael Crooker.
Thanks, Tony. So as Tony's mentioned, and as you've undoubtedly heard many times, the healthcare reform law requires states to establish exchanges by 2014. So for states that did not or have not chosen to establish their own exchange, again, at the risk of being redundant, there are two really options if you choose not to operate your own exchange independently. One would be for the state to participate in the federal exchange, and the second would be for states to opt into more of a hybrid where the state would perform administrative tasks and yet the coverage would be provided through the federal exchange. So the question that we often get is, so what does an exchange do? And I think that the best way to start by defining what an exchange does is to tell you what it doesn't do. So the exchange is not an insurance company. The exchange does not provide insurance. I think as James mentioned during our polling question, the high-level goals of the exchange, one would be to create competition and create a marketplace where insurers can come and compete for the individual and small group markets. And then the second goal would be to provide an opportunity or a marketplace where uninsured can come and presumably purchase coverage at a lower rate than maybe they would be able to out in the individual market. So those are the high-level goals of what the exchange is intended to do. But some of the particular functions of the exchange would include certification and decertification of qualified health plans, which we'll discuss a little bit later. Assigning quality and price ratings for the qualified health plans, as well as providing standardized information regarding the various health plans provided under the exchange so that consumers can adequately judge between the various products provided. Provide to consumers with tools for determining the cost, for determining the value, for determining how to purchase coverage under the exchange. Another function of the exchange would be to determine eligibility for tax credit. So as I'm sure you've heard, particularly if you've paid attention to our earlier webinars, there are some individuals are going to be eligible for tax credits or premium subsidies through the federal government. And so one of the functions of the exchange would be to determine that eligibility. Additionally, the exchanges would be responsible for determining whether individuals are exempt from the individual mandate based on a number of factors. And then finally, the SHOP program. This would be the program for small employers that would be available through the exchange. So the exchanges would be managing those. So I mentioned the term qualified health plan. What is a qualified health plan? So first of all, the law does not prohibit individuals or employers from purchasing health plans that are not qualified. However, any plan that's offered on the exchange must meet certain qualifications. And so this is a qualified health plan. A lot of people will refer to it as a QHP. I think, in fact, in our slides we use that acronym. So first of all, a QHP is a plan that's been certified by the exchange. So the exchange would take a look at the plan and certify that, first of all, that it's providing essential health benefits, and second of all, that it's offered by a licensed insurer that offers at least one silver and gold plan, which again we'll get to the silver and gold in a little bit. But the insurer would offer at least one silver and gold plan, and then complies with other state exchange requirements. So as long as you have those factors in place, then the plan would be considered a qualified health plan. So what are essential benefits? An essential health benefits package is one that really has to meet three criteria. One is that it provides essential health benefits. Second is that it limits the cost sharing that individuals would need to pay. And then the third is that it provides a level of coverage that meets one of the metal tiers, which again we'll discuss in a little bit. So there are generally 10 categories of services that each plan must provide in order to be considered essential health benefits package. So we've got those listed here on the slides, but they'd include ambulatory emergency services, hospitalization, pediatric services, and things like that. So these are the 10 that broad categories that each plan must provide in order to be considered to provide essential health benefits.
Michael or Scott, does anything on this list look unusual from a normal plan that would be offered through a small business or large employer?
No, I think for the most part, as we have looked at our clients' current plan designs, I would think the vast majority of them contain all of these categories. So I don't think there's really anything new by way of an additive category that doesn't already exist. I think most would satisfy this requirement.
Yep, I would agree.
And take that one step further, since really the exchanges is moving us to a lot more individual insurance plans. Is this unusual from an individual purchasing an insurance plan currently?
No, I don't think so. I think for the most part, this level of coverage or these categories are going to be included in most individual policies. We don't do a lot of work per se in that individual market, but I think that for the most part, these are going to be very typical categories of care or coverage available both in the employer-sponsored market today and in the individual-sponsored or the individual marketplace.
So the Health and Human Service Agency is charged with determining what the required scope of benefits is among those various services that are available. But as Scott mentioned, it's expected to track with what you would typically see in an employer-sponsored plan design, and probably most likely in the same with the individual market.
You know, one comment that I would make there too, just as we think about these requirements that are specific to the exchange, A lot of these things that we're talking about and are going to cover are also applicable to the non-exchange world as well. So they're going to apply to small group products offered outside of the exchange as well. So even as an employer, if you don't expect to purchase through the shop, you could still be impacted, or you will be impacted by the things that we're talking about in the small group market outside of the exchange.
And Scott, that's because is it because insurers will limit the products that are available to those that would be available in the exchange, or is it just?
It's because the Act itself imposes those same restrictions both in an exchange world and a non-exchange world to kind of create to not create an incentive one way or the other outside of some of the tax credits that you'll find available in the exchange world.
Okay. We only have 30 minutes left in the presentation, but I do want to weave in some of the questions. So if I can get you guys to maybe respond quickly to some of these. The first question I have is, can an individual go directly to an insurance company like Tony's Insurance and buy their own policy without going through an exchange?
Yeah. Tony, I would say and all due respect to your insurance company, there's no requirement that you buy through the exchange. The utilization of the exchanges by individuals or by employers is completely voluntary. So if you presently buy directly from a carrier for an individual policy, you would continue to be able to buy through the same traditional channels you've always purchased insurance through.
But if you go through the public exchange, depending on income,
right,
an individual may qualify for tax credit.
That's exactly right. The only place that an individual can qualify and receive the premium assistance or the cost-sharing assistance available under the Act is through the public exchanges.
So it's worthwhile just to go through the exercise of looking at the plans on the exchange.
Absolutely.
That's certainly part of what the reason that's in the law is, to try to drive people to the exchanges.
Okay.
So there are in addition to the scope of services that would need to be provided under a contract, there are also cost-sharing limits. So these cost-sharing limits are really designed to track with the qualified high deductible health plan limits. Those would be the qualified high deductible plan would be those that are associated with the health savings account arrangement. The limits are adjusted each year based on inflation, but the deductibles for 2014 are limited to $2,000 for an individual and $4,000 for a family. And then out-of-pocket costs are limited to $6,350 or $12,700 for a family. There's also a catastrophic plan available. That would be available for on the individual market only for individuals that are under age 30 or those that are determined to not be able to afford other types of coverage. So there are a number of limitations on the price setting methods that insurers will be able to use. The limited criteria would include an individual's age, whether or not they use tobacco, whether they're insuring themselves only or whether they're insuring their family, and then also their geographic or their rating area. Other than those factors, insurers are going to be limited. They must rate all subscribers the same way. So other than those factors.
Yeah, and you'll hear in the media, the expectation that cost is going to go up in this marketplace, and for the most part, it's these restrictions that you see here that are forcing or that will force the price to go up. So if a group is on the younger side, its population is younger, they're probably going to see significantly larger increases. Conversely, if the group is older, they may actually see decreases in this marketplace, again, because of the restrictions that the insurance carriers have in terms of how they rate in this space.
Right, and then you add on to what we have here in the last bullet, which is the guaranteed issue and guaranteed renewal. When you add that on to the limited rating opportunities, that's where I think, Scott, you're right on the money there. That's where some folks expect that the cost will increase because of those items. So insurers are not able to rate subscribers based on any health factors. Additionally, as it relates to employer-sponsored plans, the insurers are not able to require more than a 90-day waiting period before allowing them individuals onto the coverage. Additionally, insurers are not able to deny an individual the right to participate in any sort of clinical trial as long as they're otherwise qualified for that trial. And then finally, they're not able to use multiple risk pools for enrollees. So there needs to be a single risk pool. So we've mentioned here a couple of times today, and I expect that you've heard of it in the past. We have these metal tiers that we have to deal with. So essential health benefits packages are required to offer coverage that meets the definition of one of the metal tiers. And so the various metal tiers would include the platinum, gold, silver, bronze, and by definition, they're 90%, 80%, 70%, or 60% of the full value of the benefits. So the level of coverage, what tier you fall into, is going to be determined by the actual actuarial value of the plan. So what's the actuarial value of a plan? So we see these 60, 80, 90% numbers. How do we actually get to that? So the actuarial value of a plan is going to be measured as a percentage of the individual's costs, the cost that the individual is expected to pay compared to the overall cost of any type of service. And so when you take any service, so let's say that it's a routine doctor visit, what cost is the individual expected to pay as compared to the plan for that total cost? And that's how we assign a percentage and therefore a metal tier.
Let me see if I understand that right. If I choose a bronze level, a lower premium plan, I should be expected to have a higher copay deductible structure in order to compensate for paying the lower premium.
That's right.
Okay.
So remember, as we mentioned earlier, to be qualified, to be considered a qualified health plan, or to be a qualified insurer, a certified insurer in the exchange, insurers are required to offer both at least one silver and one gold option. So while to be a qualified or to be a qualified health plan, you only have to be one of the three or one of the four options. To be a certified insurance company or certified carrier there, you would need to offer at least a silver and a gold.
We have our next polling question up. People are already responding, but in response to the Accountable Care Act, how likely are you to make significant changes to your group health plan between now and January 1st? And anywhere from very likely to somewhat likely, very unlikely, and I'm lost and I have no idea what to do. And we have a very intelligent group of people on the webinar today because you have not selected D, but C is at almost 50%, very unlikely that you'll make significant changes to your group health plan between now and January 1st. But about 40% of you are somewhat likely or very likely to make changes.
So Scott, in your travels, what are you seeing with clients? Are they making changes here leading up, or are they?
I think that up until this point, most employers have struggled to kind of get their arms around what healthcare reform is and the impact that it's going to have on their benefit strategy moving forward. And I think we're just starting to get into or approach the early phase of, strategically then, what are we going to do once we've been able to quantify the impact of reform on their strategy. So I think it's still early there, and I don't think a lot of people have yet begun to formulate what they're going to do. But that's what I've been seeing as of late. So I think we're kind of in the early stages of the strategic considerations.
So so while some may think it's too early, is it too early?
No, I think now's the time.
Okay.
If you haven't begun that planning process, start now. The last thing you want to do is wait 2 or 3 months before your January 1st renewal date. At that point, it's likely too late. So start early.
So I know a lot of the reason for folks delaying or waiting on anything is that there seem to have been a lot of uncertainty as far as, a lot of practitioners like us were saying, we don't know enough about this yet. We haven't received enough guidance yet to really give you any direction.
Yeah.
Are we starting to see that guidance or sufficient guidance to give direction?
Yeah, I think most of the needed guidance has been released. There's still some things that we're waiting for, things like definition of a seasonal employee or how temporary or contract employees will be handled. But for the most part, I think the vast majority has been released, and we're in a spot where we should feel comfortable formulating strategy.
All right. Why don't we turn to James? Why don't you take us through this next section?
Sure. Thanks, Tony. What we're going to spend a little bit of time talking about now is how we're going to interact with the exchanges, how the exchanges really are going to, public and private, impact individuals, small employers, and large employers as the whole Affordable Care Act changes come into play in 2014. As we kind of alluded to earlier, the public exchanges, the expectation is if this is successful, it really is going to become the epicenter for small employers and for individuals to acquire their coverage. Once again, we're trying to broaden the base of people that are covered, thereby spreading the risk out amongst a larger group of people, reducing the number of uninsureds in the world, and increase competition. And the idea being here that these public exchanges are going to be like a Lending Tree or Travelocity kind of place where you're going to go in, be able to enter some data, make an application, and receive multiple offers back from multiple providers very, very promptly. And that transparency, that immediacy of return, and the ability to compare providers at a very direct level is really the crux of what the exchanges are all about. Ideally, the exchanges will have a variety of carriers included amongst them. That is one of the goals. I will tell you that at this point, that is varying pretty widely from state to state. There are a few states out there that at this point literally have one carrier that have signed up to be on the state public exchanges. Now, these tend to be smaller states where perhaps one particular carrier has a very dominant position in the state, and other states, though, have seen as many as 12 or 15 carriers sign up to be on the public exchanges. So it will be interesting to see, depending on what state you're in, and if you're an employee or you're an individual and you're looking to buy coverage on an exchange, you're going to be buying coverage on the exchange for the state in which you reside, not necessarily the state in which your employer is located. For those, like, for example, where I'm from, where we have a lot of people who are crossing borders every day to go back and forth to work. The carriers and the exchanges will continue. The carriers will continue to assemble their network of providers, doctors, and hospitals the way they always have. That connectivity between the carriers and the providers is going to be very much as we've always seen it, and in many respects, this structure is going to be very similar to what we see today once we get to the carrier level. The critical difference is now we're going to have a portal that's going to allow us to access this coverage. So, what is going to drive people to the exchanges? Well, on the individual side, one of the critical elements that is going to drive people to the public exchanges is it is the only place that individuals will be able to receive premium assistance credits and cost-sharing credits, cost-sharing subsidies that would pay, for example, part of the out-of-pocket or copays that might be associated with the plan. And very quickly, remember, this is for individuals who are between 100% and 400% of the federal poverty level, or families that are between 100 and 400% of the poverty level, can receive subsidies either to help pay the premiums for their coverage or to help pay some of the cost-sharing portions of the coverage. What I would do is I would just remember 400% of the federal poverty level for a family of four is effectively $90,000 a year. So the number of people who are going to be eligible to receive some level of subsidy for buying through the exchanges is pretty significant, and I think will have the impact that they're really looking for, which is to drive people to these exchanges to purchase their coverage. Once again, this is kind of, for those of us who are visual folks like myself, another expression of that we're really looking at dividing people up into these groups. Who's going to be covered by Medicaid? Who's going to be covered by who's going to be eligible for coverage by the exchanges and subsidies in the exchanges? And then in this expanded Medicaid area, who are those people in that area between 100% of the federal poverty level and 133% of the federal poverty level, where we're going to see them potentially either eligible for maybe Medicaid or the exchange, depending on the state they're in and certain circumstances. Now, the interesting thing about the exchanges is the public exchanges is one of their requirements is that in the application process will be to determine whether individuals are subject for the premium assistance or the cost sharing subsidies, or whether they're eligible for example, Medicaid or other governmental programs. As a result of that, and for those that become, for example, might be eligible for Medicaid, they will be redirected in the application process to Medicaid to obtain coverage through that program. So because of this, what we're really expecting is on the fringes of this, of the exchange operations, we're expecting to see a lot of movement back and forth of people between Medicaid and the exchange coverage, depending upon periods of unemployment, periods of low employment, and the like, where people might move back and forth in terms of eligibility. Now, probably the second biggest driver that I think is expected to pull people into the exchanges is flexibility, consumer choice. Exchanges you're going to be able to go onto these exchanges, you're going to complete your application, you're going to receive multiple offers of coverage at different levels, whether they be bronze, silver, platinum, gold, or otherwise, and you'll be able to compare costs, benefits, and the like to determine what coverage makes the most sense for you. Employers, for small employers who are purchasing through the public exchanges, they're going to be able to specify, for example, a level of coverage that they're going to offer through the plan, and the employees will then, at some point, be able to go in and choose from among multiple potential offers of coverage, even inside of employer plans. Now, a couple of quick things. One is, for individuals who are buying through the exchanges, that premium's not going to be payable with pre-tax dollars out of your 125 plan. For employers buying through the exchanges, you should be aware that at least in the public exchanges for the first couple of years, it is unlikely that we're going to be able to offer the multi-carrier, multiple benefit structure option because at the moment, quite honestly, the technology hasn't caught up with the ability to provide those benefits. So at least initially, expect in the public exchanges that employers will be selecting a single carrier, single plan, and providing a particular level of coverage to their employees. By 2015 or 16, we fully expect that to be a multiple tiered, multiple carrier possibility inside of the public exchanges as well. Moving on into the small business area, once again, this kind of reiterates that we really are going to have a single option in this initial year. The small business health option plan, the SHOP plan, the intention is for it to be a multi-carrier and to be able to offer multi-carrier, multi-benefit structures at some point, which we would expect by 2015 or 2016. At the moment, that as we kick off in 2014, in most states, the employers with fewer than 50 employees will be able to buy through the SHOP program. By 2016, we expect that number to be up to employers with 100 or fewer employees to be able to purchase through the SHOP program. So what do we know about the exchanges? What do we know about the challenges that they're going to face at this point? We know that, for example, education call center customer service assistance is going to be an enormous challenge here in the early years of the exchanges, because it's a completely new methodology and way for people to access coverage. Literally, some of it is practical and as simple as how to make sure that premiums are paid when you're dealing with people who, for example, may have no internet access, may not even have a bank account, and how are we going to collect and make sure that the coverage is maintained for people who may be receiving partial subsidy through a federal premiums assistance, but otherwise, are struggling day to day to meet bills, make payments, and somehow or another are going to have to figure out how to get this money into the exchanges to pay that healthcare, to pay those healthcare premiums. I think it's an enormous IT challenge that is yet to be completely figured out, and I think that is why you've seen here in this first couple of years on the public exchanges in particular, where they're going to limit that shop selection to a single carrier and potentially to a single plan, because aggregating carriers and aggregating premiums at this point is a technological challenge that I think that has not yet been completely pulled together at the federal level.
I think states, though, that are running the exchange themselves, there's a higher likelihood that the multi-carrier options will be available there. It's definitively, though, I think, in the federally run exchanges where that's not going to exist.
And I think that that's really true. In some respects, it will depend also on a state-by-state basis in terms of how they structure their exchanges. I think Massachusetts has an advantage. They've had one for a while. But, for example, if you look at Utah has taken the approach, the state-run exchange, but they've taken the approach as to be a very low-level service, administrative service portal to multiple carriers. And so the level of activity and the level of involvement that the states choose to have in the exchanges will, I think, also determine in large respect how quickly they're going to be able to implement this multi-carrier, multi-tiered access to coverage.
That brings us to our next polling question. Based on what you know today, how likely are you to consider purchasing health coverage through a public or private exchange? A, very likely. B, may consider. C, staying with your current provider. Or D, too early to tell.
It looks like we're heavily in the staying with current providers or too early to tell area, which honestly I think is what I would expect at this point in the game. In most instances, we're working with our current providers to help us develop a strategy for addressing healthcare reform, which in large respects should engender a desire to stay with the carrier who's leading you through the process. But I will also say on the too early to tell side, where I think we've got about 25% of our people in that area as well, it is going to be about over the next year to year and a half, as the exchanges go live and we see how they operate, it's going to be interesting to see what dynamics take place in the marketplace.
Have any of the large national carriers communicated that they're not going to offer any plans on the exchange?
Yeah, in some states, I know there was press recently in California, as an example. United Healthcare, Cigna decided to not participate in that public exchange. That's just an example. I'm sure there are others throughout the country as well. But
does that open up opportunity for smaller carriers to actually introduce their products into markets?
Yeah, it very well may. Sure.
And honestly, I think that's one of the great fears of many carriers who may have very dominant positions in some of the states, that smaller, more aggressive carriers may see the exchanges as an opportunity to gain market share, may aggressively go after that market share. And in all honesty, at some level, that's part of what the federal government's hoping will happen, because they think that competition will be good. It will drive efficiencies and drive reductions in cost, or at least slow the growth in the cost of coverage. What I'd like to do right now is spend the rest of the time that I've got really kind of talking about the difference between public and private exchanges, and talking about really where private exchanges are going to fit into this whole equation. Private exchanges will look for all the world at the surface very much like the public exchanges. They're not regulated by the states in the way that the public exchanges are. They're a distribution channel, oftentimes set up by either large insurance brokerage firms or benefit consultants, or in some cases, even single carriers have set up their own private exchanges. Interestingly enough, because of the way they are, they will be structured, and the ability to be more flexible than the public exchanges is they are likely to have a much broader variety of benefits available under them, some of which aren't even capable of being offered on public exchanges. For example, you could have benefits that include a variety of voluntary benefits far beyond the qualified health plan types of benefits, whether they be individual illness policies like a cancer policy, whether they be life and disability policies. In other words, to these groups, it's going to be a distribution channel to which I would expect you to see a very wide array of benefits brought to play. And the most significant difference is large employers can buy from private exchanges. It is a way for brokerage companies and benefit consultants to offer the wide variety of multi-carrier, multi-tiered, multi-structured benefits to an employee on a cafeteria kind of basis that they may not be able to offer right now. Now, probably the most interesting thing that has come out of some of the movement we've seen to this point is a growing interest in utilizing the exchanges, public and private, but particularly in the private arena, to move benefit plans away from what we would call, say, a defined benefit kind of approach to a defined contribution kind of approach. Historically, an employer has gone to their carrier, gone to their broker, gone to their consultant. They've identified a carrier. They've identified a specific plan, maybe sometimes one or two plans, and gone to their workforce and said, here's what you're getting. We've defined the benefit that you're going to be able to get. Well, interestingly enough, in the private and public exchanges now, particularly on the private end, what you will see is an ability to go and say, here's a menu of carriers, here's a menu of plan options that are available to you, and you can limit them and restrict them to some degree, or you could literally allow people to buy whatever is available on the exchange, and for an employer to move to what's called a defined contribution kind of approach and say, we're going to give you multiple choices, multiple carriers, multiple plans. You've got X $1,000 a year to spend on your group health coverage. Spend it any way you want. Pick the plan you want. Pick the benefit level you want. You pay the difference between whatever we put up and whatever the cost is of the coverage that you want. I think there's an enormous amount of interest that this defined contribution approach to benefit design and structuring will be a way that for employers to move toward greater control over their group health benefit costs.
James or Scott, are there certain industries that would have a propensity to move to that quicker than others?
I don't think, not that I can think of off the top of my head, why any one industry might be more attracted than the other. Honestly, I've not, in my travels, heard particular industries favor that more than others. So,
based upon competition for human resources, could that be an indicator they may be slower than?
Well, I think there are ways, even in the traditional, through various contribution strategies that an employer could take advantage of today. You could effectively duplicate that defined contribution type effect just through a very specific contribution strategy, so that there's another way to accomplish that without having to actually purchase through one of these exchanges. So that may be part of it.
So, I think what we will find is, particularly in the large employer market, is we will see, large employers, those working with some of the larger national benefit consulting firms and brokerage firms, will start to see these firms bringing the private exchanges directly to the employers and saying, hey, here's an alternative that is really an outgrowth of what's happening here with the Affordable Care Act. It's a way to offer a wider variety of benefits to your employees, and in essence, hopefully increase the satisfaction of your employees with their benefit programs, and a way through a defined contribution approach to potentially have a little bit better control over what your benefit, the increasing cost of your benefits over time. This slide, is really here to kind of give you an idea of what we're talking about when somebody goes into an exchange and completes an application. The idea would be at some point you would come up with a series of options kind of summarized one next to each other so that the employees can really, the individuals or the employees can really kind of compare. If I buy this plan, it's a lower premium, but my out-of-pocket costs go up, my co-pays go up. If I buy this plan, my cost, my overall cost is higher or lower, but at the end of the day, where is it going? What is my end of the day cost? What is my end of the day maximum exposure? How healthy am I? How healthy is my family? The real goal is to turn our individuals into better, more educated consumers for their health care coverage. So once again, these really are a distribution channel, whether they're public or private. It really is a way to get product out to the consumers. Ideally, it's going to be a way to coordinate multiple carriers and underwrite multiple plans across a broad variety of benefits. Either the vendor or the employer can establish either menus of benefits or limitations on those benefits, can establish cost-sharing relationships on that benefit, on the benefits in terms of the defined contribution kind of approach. And ultimately, the exchange is going to be the aggregator of all this information. You may hit, in a large employer that goes, say, the multi-carrier, multi-tiered benefit structure. If you've got 1,000 employees, you may have, people on 10 or 15 different plans with 4 or 5 different carriers, and ultimately the exchange is going to be the place where all of that information is going to be aggregated and where it's going to be brought together, and the billing is going to come through on a single bill to the employer just the way it is today, except that you're going to be offering benefits and paying for benefits across a wide range of carriers. So I guess what we don't know today, there's a lot of things we don't know today, but one of the things that we really don't know today is this transparency and choice really going to make a difference? Premium assistance, greater access to expanded Medicaid, the cost-sharing assistance that's going to be available to individuals through the public exchanges. The real issue is this going to drive people to the exchanges? Is it going to decrease the number of uninsured people out there in the marketplace? Will companies adopt and move toward the exchanges as a way to offer broader and a greater variety of benefits? These are questions that are going to be answered over the next 2 to 3 years to see whether the exchanges really take hold and whether this is a transformative moment in healthcare in the country. Now with that, I think we're going to move. We've gotten a few questions from folks as we've been talking here, and we're going to try to answer as many of these as we can before we run out of time here this afternoon.
All right, we do have several questions here. Let's see. I've heard that exchanges for large employers will not be available until 2017. Is that correct?
Well, public exchanges will be limited in most instances will be limited to 50 or below until 2016, at which point we expect to see the public exchanges go to 100 or employees or below. There isn't any specific guidance, isn't any specific thing in the law at this point that would cause the exchanges to open up for employers above 100 at this point. Now, in the private exchange area, it really probably is more directed at the larger employers than the smaller employers anyway. So at the private exchange level, that will be, who will be eligible to buy through a private exchange is going to be completely at the discretion of the organization sponsoring that exchange.
Here's another one. I have heard that Medicare beneficiaries can also go to an exchange. Is that true?
Medicaid individuals are not eligible to participate on the exchange. Oh, Medicare. Yeah, so Medicare, if you're eligible for Medicare, then the exchange is definitely an option.
Mental health coverage was dropped from our plan after the first wave of the Accountable Care Act was implemented, and it no longer allowed limits on the coverage if the coverage was available. We have greater than 200 employees in a self-funded insurance plan. Will the essential health benefits list of 10 items now mandate that coverage be restored?
I mean, I think that the answer to that is likely going to be yes, that it falls under what would be considered essential health benefit.
Yeah, but in a self-funded environment, the employer is not the list of essential health benefits is different. And to be honest, I don't know the answer to that off the top of my head. We'd have to.
Yeah, I think that the list is different. But I guess my suspicion is that over time that these are largely going to track with each other. That would be and I don't know that I have specifically that the law or the regulations have cited that, but I would expect that they're going to track closely.
We will be publishing answers to all of the questions that have been submitted through this process. So we will definitely make sure that we research that further and post that accurate answer once we've had that opportunity to go back and look and verify.
I think that we referenced this earlier, but somebody's asked, if you live in a different state than your employer, which state do you use for the plan if he goes to the exchange?
An individual will buy their coverage through the exchange that for the state that they live in. So if you're and that is going to be early on here in the public exchange arena, a real challenge for employers who have employees in multiple states. That you will have employees who will be directed to the state of their residence to buy their coverage through the public exchanges. So if you have employees in 4 or 5 different states, you could have employees on 4 or 5 different exchanges with potentially 4 or 5 different benefits.
Does that only matter if they're purchasing through the shop? If they go to a defined contribution plan, does it matter that an employee is purchasing it through another state?
It does. No. What it does require is that if they're buying individually, obviously they buy in the state in which they live. If they're buying through the shop, once again, that the employees are going to be purchasing through the exchange of the state in which they reside.
Okay. See, we got a couple more questions here.
I will tell you though that there is the opportunity is available for the state exchanges to form multi-state cooperative agreements with each other and have regional exchanges and potentially national exchanges, even in the public environment. This is going to be an evolutionary process. At the moment, I think the struggle is just to get the darn things open and functioning on time. But over time, I really would fully expect to see greater levels of cooperation, even amongst the state public exchanges, where particularly the large national carriers who may be offering benefits through most or multiple of the exchanges, so employers with employees in multiple states can have a more seamless single point of access for all those employees.
We have time for 1 or 2 more questions. Here's a great one. Will the penalty tax an employer pays, the $2,000, increase dramatically as employers drop health insurance and push employees to the exchanges, or is it a fixed fee for a set period of time? If an employer does not offer a QHP and pays the penalty, the employee becomes eligible for the credits towards their premium, ?
Yeah, so if an employer offers a plan that does not meet either the minimum value assessment or the affordability assessment, and the employee earns less than 400% of the federal poverty limit, then that individual, that employee, would qualify for a subsidy through the public exchange.
With that, we're going to conclude today's presentation. I want to thank Scott, James, Michael for your time today. And again, this will be posted on our website in the next couple of days. Thank you all very much.